Hello, my name is Drew McKelvin, and I did a project with Brandon Stump, Charles Ellison, and Jarrett Mitchell. And our project's name is Nursing Implications on Family Presence During Resuscitation. Family presence during resuscitation is one or more family members are at bedside while the patient is having CPR performed on them. Also, few hospitals nationwide have protocols in place to accommodate such a practice, and the few that do, the protocols are evolving, and this is a fairly new idea compared to traditional U.S. medical and nursing practices. The challenges to nursing include family presence during resuscitation is often not a practice that is accepted by nurses across the board. Another challenge is there are several factors that lead to this, and the challenge involved to evaluate whether the practice should be continued or done away with altogether and take a united stand one way or the other. These include legal, ethical and moral, holistic, and outcomes-based factors.
Hey, I'm Charles Ellison, and I'm going to talk to you about the barriers versus benefits of the family presence during resuscitative efforts. During a code situation, it presents the nurse with potential barriers and benefits with regard to whether the family is there and present. It could also affect the patient and the familial outcomes. Some of the barriers that we're going to talk about, you have the patient familial presence leading to interruptions in processes. If there's not a designated person to try and help them out, they may be trying to ask people who are working on their loved one and who are really busy at that time, and it may interfere with some of the care that's given. Plus, they may act as a physical barrier in a really cramped area. There's also a risk for lawsuits from family members for various reasons, including performance of the code team and staff during the event. If they see something that's done wrong, it's different when you're alone doing it versus a family member watching on, because if they see something that they don't feel was right, they may go find a lawyer. Who knows, they may be a nurse, a doctor, or they may have a family member that's a lawyer. So this is potentially a concern for a nurse because they don't want to be sued. There's also the nurse commitment to follow set protocol for the process. So the nurses have to ensure that they're following what the hospital does to ensure that the whole situation is handled properly. There are barriers to the family presence that include the fear of interference by the patient's family, lack of space. Like I mentioned earlier, if it's an ED, that's one thing. There may be enough room down there, but sometimes in a med-surg situation, it may not be appropriate for a whole family to be piled in there. There's a lack of support for the family members unless you have a designated person like a nurse assigned to kind of guide them through it. Or minister or something like that, then they may be kind of at loose ends just watching the situation. There's also a fear of trauma to the family members, and the article we read quoted emotional trauma predominantly because they're watching their loved one die in front of them. They're not used to seeing all these medical procedures being performed. Also, there may be physical trauma with them being a physical impediment if there's a lack of space. There's also performance anxiety on the nurse, and whether that could potentially hinder their performance of the code and potentially saving the patient. However, there are obviously some benefits. The nurse is able to explain the step-by-step procedure to family member. That's if you have a designated nurse to try and explain and guide them through the process. There's a heightened awareness of the code team members to practice sensitivity during the event. So, whereas there's never probably joking in this kind of situation, but you need to just be aware the family member is there and show the proper respect. And also, familial coping is improved no matter what the outcome. If the patient lives or dies, it may enhance their grieving process to have some closure, to be able to see what goes on and that everything was done for their family member. Also, it may lead to shorter codes due to family intervention if they see that their loved one doesn't appear to have any hope and their loved one's been through enough, and we're still trying to do cardiopulmonary resuscitation and starting up with interventions that may be invasive, then they can kind of put the halt on that and tell us that they want to go ahead and let them go. But thank you for listening, and I'm going to hand this program over to Senior Stump, and he'll continue it for us.
Thank you, Charles, for handing this over to me. And speaking about the barriers and the benefits, I'm going to talk about overcoming the challenges that are seen with having family members in the room during resuscitative measures. We have found that the only viable option is to have an establishment of a unified and uniform approach to the event process and adherence by all the participants. There are 3 methods to go about doing this. The first is to have an education and training, including simulation of events, to evaluate processes and determine areas for improvements. One of the articles, we have a quote that talks about how the more people were able to run through simulations, the more comfortable they would feel with the family in there. We as nursing students have seen this as before we were even allowed to go into the hospital, we had to run through SIMS labs just to get comfortable with going through the process and handling drugs or Foleys or anything like that. So that is definitely a benefit. The next step would be involving ACLS training for nurses to improve awareness of processes during the event. Another article that we had spoke about how nurses that worked in the ICU and had been involved in more than 10 resuscitation events were trained in ACLS or had gone through mock codes. They showed that they had more self-confidence in the live situation. We know this as well. Practice makes perfect. The more that you're doing and seeing, the more confident you feel in your skills. The last intervention that can be had is you'd want a nurse of more experience involved in the FPDR event. Another article spoke about how you'd want a nurse with 10 to 20 years of experience, and this is just, they've seen it, they've done it, they just have that more, they just have a caring nature about them to handle the situation that arises. They've been there and done that. So all of these interventions, again, will lead to the viable option of an establishment of a unified and uniform approach to the event process and adherence by all the participants. We don't want any loose strings on anybody's end. And I'm going to hand it off. He's last on our slides, but number 1 in your hearts, Jarrett Mitchell.
Thank you, Mr. Stump, for that glorious introduction. And now we'll be moving to our recommendations for the professional nurse involvement. So overall, there were several different options for interventions to overcome the challenge that we were posed with. Some of the recommendations we came up with were, number 1, to have all ICU and critical care staff have ACLS certification, and then maintain that certification during your stay of employment. It's been proven that ACLS certification will greatly improve your confidence and all that in a code situation, which, as we all know, was stated earlier, that a lawsuit is one of the biggest factors that people are frowning upon family presence during resuscitation, and that can all be avoided if the nurse is confident in what she's doing or what he or she is doing. Then that's much less of a likelihood. And some facilities could even possibly entertain the idea of having financial incentive for the certification and maintenance of the certification for the stay of employment. Another recommendation that we'll have is to advocate that all nursing staff participate in quarterly SIM codes where possible, or participate in a code response team within the facility to gain experience and proficiency. And by this, we're talking about, like just regular floor nurses that are not acute care nurses, that are just tagging along with the code team or whoever, if the facility has a code team. If not, then to go do as many codes as possible. But that's just to help gain experience and proficiency. Repetition is the key, and repetition of experiencing the resuscitation events will increase role-specific knowledge and your proficiency in your role. Also, it'll increase your knowledge base. It'll increase how you feel you perform in, if you're the drug nurse, if you're the nurse doing CPR, if you're the scribing nurse. It'll increase your proficiency, which will ultimately increase your awareness of the family noticing you pretty much, and it'll give you a lot more confidence, and you'll be able to do your job better. But also, you'll be able to gain more knowledge if you're ever have to be the facilitator nurse and we'll get to that in just a second. If you ever have to be the facilitator nurse for one of these things, where the family comes in, then you want to make sure that you know what's going on, and you can speak for each action that they're taking. Lastly, we want to establish a protocol that gives the specific guidelines to how family presence will be offered, implemented, and then later followed up on, and ensure that there are appropriate staff between nurses and other ancillary personnel before it's even offered. Make sure you have, a nurse that's specific to the family members, or just the family member. They're often called a facilitating nurse, but you want to make sure you have the one nurse that is specific to the family, and then also on top of that, make sure you're not sacrificing other personnel that are your drug nurses and your scribing nurses and all this stuff. Overall, just be smart about it. Make sure you have chaplains there for follow-up, and in case the outcomes are not optimal, which oftentimes if they're in a code situation they're not, but you just want to make sure you have all your bases covered first to take care of the patient, and then any extra staff that you have, such as a nurse that can facilitate with the family, you want to make sure you have them there. And next up, we're going to show a video about how family presence during resuscitation should be run. It was a very well thought out video that some nursing students had done, and we thought this was a good idea to show you what family presence during resuscitation would look like.
Good morning. How's Carl doing today?
He's kind of quiet. He hasn't been talking very much like he was yesterday.
Okay.
His hand's a little sweaty, and he's just not responding to me.
Okay. We'll check him out here and see if we can figure out what's going on. Call Code Blue, get a cart.
Is he okay?
Sir, if you can just step over here with me a minute. I'm the nurse facilitator. And are you okay right now? Your family member's in a life-threatening situation, okay?
All right.
Now, do you want to stay here and be present for this?
I'd like to, please.
All right now, it looks like that he's in a fatal heart rhythm, okay?
Okay.
And they're doing everything they can to get that situation straightened out, okay?
Okay.
Do you have any questions?
What are they doing on him?
Well, they're doing chest compressions. And chest compressions actually circulate the blood to the vital organs while his heart is unable to pump that. As you can see also up there, they're also giving him oxygen and ventilating him with the bag so he can actually get some oxygen to his organs as well. Okay. Do you have any other questions? Did you want to sit down?
No, I'm fine.
All right, well, if you want to just touch him on the leg there and just let him know you're here.
1, 2, 3, 4, 5, 6, 7, 8, 9.
Do, re, mi, do, re, do, mi, do, sa. Okay, you've seen our videos, you've seen the PowerPoint, now we're going to get to the conclusion of our presentation. We've come to the belief that a unified approach to a standard protocol holds the best chance for success of coping for the family and reducing risk for negative personnel involvement when family is present during resuscitative efforts. We all had different viewpoints at the beginning of this. Me personally, I did not think it was wise to have the family in the room. I feared of lawsuit issues, just interference in general. But after doing this project, have learned that for coping measures and for better care, we're not just giving care to the patient, but to the family as well, that I do find it better to have the entire family in the room, or a family member in the room, if possible.
I kind of felt in the beginning that the patient and the family are the customer and we're the service provider, and that we had a duty to go with whatever their wishes were. If they wanted to be in the room, then they should be in the room. I understand now logistically that there are more issues with the code, especially if you're in like a small med-surg unit, as far as like the size of the room and, you know, other issues people run around, you know, just also the emotionality of the whole thing. as well as issues with having to assign a nurse maybe to explain to them what's going on. It might limit staffing.
I was really mixed on the issue. I felt that the family should have the opportunity to be there, unless they are unrealistically emotional with the whole ordeal. But I really felt the need for the family to be there. I thought it would really improve the patient's chances and everything.
I honestly think that, in the long term, looking at things, the family has the right to choose whether they want to be there or not. And I think each family member can attest to their own ability to either accept or wig out during the situation. And like we said earlier in the thing, in the presentation, it's really important to have that resource nurse, the facilitating nurse, to guide the family member and explain step by step what's going on. I think that's the real deal breaker in the whole process of what makes the process successful or unsuccessful. So all in all, we're kind of united now that we think that more needs to be done in looking at protocols and how we can say, okay, this is a standard protocol across the board, and not each hospital doing this, that, the other, but have a nationally recognized protocol for this. Either that, or let's just do away with it altogether and do it how we used to do. So thank y'all for your time, and Godspeed.
Boom shakalaka. Bye bye.
We them boys. Do re mi do re do mi do sa. Ah, so when ya